نفتتح المؤتمر، هو المؤتمر الثامن للجمعية الأردنية لأمراض الروماتيزم، والمؤتمر الثالث للجمعية الفلسطينية، والرابع لليفانت Rheumatology Summit 2025. بنرحب فيكم جميعا، ويعني هاي الجلسة بصراحة هي to encourage young rheumatologists يحكوا لنا عن their work and their presentation. فأول سبيكر عندنا الدكتور حمزة نسور. He is a pediatric immunology, allergy, rheumatology and bone marrow transplant fellow at Royal Medical Services. And he will present autoinflammation versus autoimmunity in 3 children. What is the definitive diagnosis? So most welcome, Dr. Hamzah, and the floor is yours.
Thank you, Dr. Manal, for introducing me. First of all, I would thank the scientific committee of the Congress for giving me the chance for being here today. So I will talk about 3 cases that share different phenotype, and then we'll end with the same molecular and genetic diagnosis. So my first case is about a 14-year-old female patient. Since the age of 7 years, she started to complain from recurrent oral and genital ulcers, generalized weakness, and morning stiffness of more than 30 minutes. She was treated at that time as juvenile SLE with systemic steroid, and at the age of 12 and a half years, she presented to our clinic at Queen Rani Children's Hospital with generalized weakness, facial redness, morning stiffness, oral and genital ulcer with bilateral wrist swelling, with no any CNS manifestation or GI manifestation, and no hematuria. Actually, she had a very devastating and dramatic family history in terms of her father labeled as rheumatoid arthritis since 2007, and Crohn's since 2017. He was maintained on systemic steroid, Humira and Imuran, and he died at the age of 44 years after he developed sudden severe abdominal pain and found to have bowel perforation and died due to sepsis. Her elder brother, at the age of 5 years, he started to have easy fatigability, anorexia, prolonged fever, and cytopenia, and bone marrow study was normal. He was treated by systemic steroid as systemic inflammatory response syndrome and showed good response. Then, at the age of 6 years, these symptoms recurred, in addition to malar rash, oral ulcers, and he labeled as juvenile SLE. Unfortunately, at the age of 14 years, he again developed severe sudden abdominal pain and found to have intestinal perforation, and unfortunately, he passed away. Her brother, at the age of 13 years, developed suddenly unexplained pallor, found to have low BCV, and given 2 units of packed RBCs, found to have positive DARCOM cysts as autoimmune hemolytic anemia with high inflammatory marker, with ENA positivity of M2 and PDC, and blood film was consistent with hemolysis. So back to our patient, she open examination, she has positive Gowers sign, positive malar rash, mild heliotrope rash, with pulmonary erythema, with small two painful oral ulcers, with small bilateral cervical lymph node enlargement, with babular skin rash all over body, mainly on the upper extremities. She had normal chest bilateral, normal heart sound, no hepatosplenomegaly, and no skin ulcers or digital ischemia at the time of examination. So her initial workup, she showed lymphopenia, high inflammatory marker, a high total protein to albumin ratio with hypergammaglobulinemia. Her ANA profile was positive. ANA profile was positive for double-strand DNA with the nucleosome, ribosome, P protein, and AMA-M2. Her ANCA profile was negative, and antiphospholipid antibodies were also negative, with HLA-B51 was also negative. Her ophthalmic, cardiac, and MRI were all normal. So our initial impression was between monogenic lupus and overlap syndrome. We started her on Imuran, steroids with hydroxychloroquine. So in June 2023, she developed left-sided axillary large abscess, which need insuffisant and drainage, and culture showed MRSA infection. So based on the strong family history of rheumatological disorder and clear symptoms and signs, genetic study had been sent. So going to another case, which is a 24-month-old female. At the age of 16 months, she admitted with prolonged fever, cytopenia, high inflammatory marker, and splenomegaly, treated at that time with high-dose dexamethasone, and she showed impressive response. Here is her initial workup, as I mentioned. The significant part here is she had a hypergammaglobulinemia. Bone marrow aspirate showed scattered histiocyte, and after tapering steroid at the age of 21 months, she readmitted with a prolonged fever, high inflammatory marker, pancytopenia, hyperferritinemia, and hypertriglyceridemia, and hypofibrogenemia. As you can see here, low BCV, ESR 100, triglyceride high, CRP very high, fibrinogen low, ferritin high, and hypergam and lymphocyte subset was normal in terms of percentages and count. Bone marrow study repeated and it was normal. She was started on HLH 20004 protocol with IVIG replacement, high dose dexamethasone and cyclosporine with prophylactic antimicrobial. So due to relapse of her HLH, genetic study was sent throughout primary HLH. So genetic study molecular diagnosis was come back for all 3 patients who has 3 different clinical phenotype. They showed the same genetic mutation, which is RELA, which is a heterozygous mutation that causes a Behçet-like autoinflammatory disease. Now it is called RAID, which is RELA-associated autoinflammatory disease. Autoinflammatory diseases are conditions in which pathogenic inflammation arises primarily through antigen-independent hyperactivation of immune pathway. First recognized in 1997 when FMF gene has been described, and since 2 decades now we have more than 40 distinct monogenic autoinflammatory disease. So the NF-κB pathway is composed of a family of inducible transcription factor which control DNA transcription, cytokine production, cell survival, and regulation of the immune response to infection. The RELA gene encode B65 protein, which is one of the 5 NF-κB family transcription factor. RELA is an essential regulator of mucosal homeostasis, so haploinsufficiency in RELA will lead to decrease in NF-κB signaling pathway, which promote TNF mucosal apoptosis with impaired epithelial recovery. So Dr. Yusuf Badran and his colleague from Boston Children's Hospital in 2016 published the first report of RELA haploinsufficiency. So what you see in the left side is the family degree with multiple children presenting early with recurrent oral ulcer GI symptom, and one of the children developed genital ulcer, and the father was asymptomatic. So on the right side, the sequencing chromatogram showed the same heterozygous RELA variant in all affected family member. So this landmark publication was the first to connect a RELA mutation with a clinical phenotype of mucocutaneous ulceration and autoinflammatory syndrome, which opened the door to recognize RELA haploinsufficiency as a new monogenic autoinflammatory disease. So this slide shows how RELA haploinsufficiency is not one disease, it is a multi-system disease. You can see immune dysregulation, hematological manifestation, rheumatological, GI, neurological manifestation like neuromyelitis optica, and some skin rashes. So RELA is really a disease that touches almost every system in the human body, and that's why these patients often bounce between specialty, between getting the right diagnosis. So in this 15 rate patient, you can immediately see the pattern. Most often worked with ulcers, oral in 60%, and genital in half of these patients. Some present with skin rash, and interestingly, many had already been given diagnosis, alternative diagnosis, before we reaching out what's really going on. So overall, these patients don't come with one clear picture. They come with a mix of inflammatory clues that can easily send you to a wrong direction. So clinically, autoinflammatory disease show up sudden. Inflammatory flares, fever, redness, swelling, because the innate immune system is overreacting, and you will not usually find autoantibodies. Autoimmune disorder, and in the opposite side, the adaptive immune system can get confused, loss of tolerance, and start making autoantibody or attacking tissue with T cell. So simply put, autoinflammation is cytokine-driven flare, autoimmunity is antibody and T cell-driven self-attack. So practically, autoimmune disease are what we see every day, which is common in females, usually show up later in life with B and T cell-driven damage. But monogenic autoinflammatory diseases are in the opposite, rare, usually young kids with no gender bias, and the problem is neutrophil and cytokine firing without a trigger. So autoinflammation come in attack, and that's why we treat autoimmunity with DMARD and B-cell depletion therapy, and autoinflammation respond beautifully to IL-1 blocker. So I will end with this. Autoimmunity and autoinflammation are the two sides of the same immune coin. What matters is knowing which side is flipping the patient disease. Thank you.
Thank you, Dr. Hamzah.